It is an absolute honor to be podcast interviewing Professor David McGowan, who's been practicing oral surgery since a year before I was born. I was born in 62. He graduated in 61. So you've been doing it 54 years, and you're 77 years old. Congratulations on a
thank you.
Unbelievable career.
My wife gets the credit for that. She looks after me too well.
So you've seen amazing changes. You were born in Northern Ireland.
Yes.
And then how did you end up in Scotland?
Well, I trained in Belfast at Queen's University, and did training in oral surgery there, and also for a year in Aberdeen in the northeast of Scotland. Then I got married and moved all in the same time to the London Hospital Medical College in Whitechapel in London. And that's where I really completed my training and became an academic. I did a PhD there in microbiology. And became senior lecturer and senior lecturer consultant in oral surgery at the London Hospital, and had a really fascinating time at the London Hospital. It was a hotbed of educational and research activity. It really was a wonderful, very stimulating place to be. Then I applied successfully for the chair of oral surgery in Glasgow and came here in 1977, and I've been here ever since. I work mainly in Glasgow, but I also had I first became exposed to and interested in postgraduate dental activity and education when I worked for Peter Clark, who was my boss in Aberdeen, and he ran a lot of courses. That was the style of those days for the local general dentists in northeast Scotland. And in fact, at one time he ran more courses in his own unit than all of the dental schools in Scotland, because postgraduate education wasn't seen as a major activity for the undergraduate schools in those days. And higher degree things and some were pretty rare. They hadn't been developed very much, although there was specialist training in orthodontics and oral surgery and restorative dentistry. So when I went to London, I used to do a weekend travelling course around various medical postgraduate centres for dentists, general dentists in the London area, and along with a colleague who was a general dentist, but interested in oral surgery and a part-time teacher. And this I find a very fascinating and enjoyable experience, and enabled us to try out techniques of small group teaching and practical learning and so on. And the postgraduate centres then were quite a new thing, and they had something of the aura of a gentleman's club. So the idea was to encourage people to come and enjoy meeting with each other. I think you probably appreciate that most postgraduate learning activity takes place in the bar rather than the lecture room, and people come to talk, and they always talk shop. That's how they learn. So I had a lot of enjoyable experience of that. So when I came here, I was keen to continue with that. And my predecessor had been responsible for postgraduate education, but not very much was happening. There were courses. They're called Section 63 courses because they're paid for by the government money from under Section 63 of the Health and Social Services Act, and these were quite well run, but they weren't taken up by everybody, and they were pretty formal, quite old-fashioned in style now. So I was keen to develop things when I became responsible for training of the postgraduates within the hospital, and also the whole of the west of Scotland, and then eventually I was appointed chair of the Scottish Committee for Postgraduate Dental Education, which covered the whole of Scotland. And it was a very exciting time to be involved with it, because there were lots of new things. I don't know how familiar you or your readers or subscribers are with vocational training, but vocational training was, the idea of vocational training was that newly qualified dentists should have, at least for their first year, a sort of formal mentorship with the principal with whom they worked. Because in the old days people were sometimes shy of asking for advice, and people were shy of offering advice, and that broke that barrier down. That was the essence of the relationship. So we did that, and we were the first in Scotland to do that, and we were only 1 year after the very first course, which was run in Guildford in the south of England. So we got support and set this up on very much on a voluntary basis. So we had about 10 participants based all over Scotland. So, and the idea then was to take people out of the practice as little as possible. So we used to meet once a month in a facility in Glasgow, a non-dental facility in Glasgow at the teacher training college, which was residential, and so we had people came for a weekend learning together, and I've always believed that learning should be fun, and that certainly there were some great weekends we had, and we got support from the Scottish Council to keep this going, and that was a sort of trailblazing thing. It's developed now until everybody has to do it before they can formally be recognised to practice under the National Health Service, and it became funded by government funding, and who pays the piper calls the tune, and it became much more formal, and people started thinking in terms of the course and the lectures and things like that, which we'd always studiously avoided, feeling people had had 5 years of that and they should have a different experience. But that's the way it developed, and somewhat distorted. I think it's more fun in the old days, but however it does work.
So when you got out of school in '61, oral surgery was all exodontia extractions.
Yeah,
and now
the disease patterns are the most dramatic change in my practicing lifetime.
Okay, talk about those. Well, how have the disease patterns changed?
Well, it was commonplace. The dental hospital oral surgery departments would be open to the public, and people would come seeking help each day. And the vast majority of people only came when they needed an extraction, and many of them needed many extractions, and it was commonplace to do complete extractions, dental clearances. We did that. We probably put maybe half a dozen to a dozen people through that every session. That's what people, it's what they wanted. We delivered it. We were very efficient at extracting teeth, and we did it very well. And we could even offer general anesthesia and so on, which is not respectable nowadays because it's considered to be unsafe, but it was actually a remarkably safe procedure. But people, you could do a dental clearance and complete extraction of teeth, and proficient at it, wouldn't take you longer than 10 minutes or so. And, it left not a lot behind, and in retrospect I suppose a lot of the edentulous patients with very small ridges and so on were due to that pretty dramatic surgery, and there wasn't any attempt at repair or rebuilding or anything in those days. It's the sort of thing that's almost inconceivable to today's patients, and laterally when I was teaching students I had to tell them, maybe that's why I'm interested in history, I was telling them historical tales of multiple tooth extractions and so on, which they'd never seen. Just as when I was a student, I'd never seen a patient with a full dentition without caries, except once. And that was a chap who came from a village in County Down in Northern Ireland, which was naturally fluoridated. And when he came in for something else, everybody came to look. It was that.
So the only one you saw that had all their teeth with no cavities was someone who came from...
One patient I remember.
Someone who came from a naturally fluoridated community. Go figure.
That's right. In those days, there were what you almost, in a way, were judgmental. There were were bad patients who didn't look after their teeth, and they had their teeth extracted one by one or a lot at once, and had dentures. And if they're going to have dentures, the younger they had dentures, the better they tolerate them. That was the theory. I don't know whether it was true.
I believe it's true.
And then there were the good patients. Now the good patients had fillings and wanted to keep their teeth, and they often became patients of the students who, I think of the restorations I did, enormous amalgams, and how long it took me. I paid great tribute to the patients. It was just a different world to nowadays. And,
what do you think's lowered the decay rate so much from having mass decay to less decay?
Fluoride toothpaste, number one, absolutely. And most people now brush their teeth with fluoride toothpaste.
But there seems to be a growing movement of all natural toothpaste in the United States, where no fluoride, no chemicals, all natural, whatever natural means.
It's a bit sad, and certainly counterproductive. Everything's chemical. I mean, chemical doesn't mean anything, but it has become a sort of a pejorative word, But everything.
I love the word all natural. I always say, what do you mean all natural? Like a tornado, a hurricane, an earthquake?
The way things work, but no, there are these fads. That's because people nowadays they're much better off. Recent statistic which interested me was 40 years ago in this country, the average family spent a third of their income on food. And now it's only 10% because food is delivered to them so much cheaper. So they eat more, eat far too much often, and so it's different. There was quite a lot of austerity around up until the 60s. I mean, I can remember rationing of sugar and sweets and things.
When was the sugar rationed?
All through the war and up till the 50s.
Which war did you remember?
That's the Second World War.
You remember? No.
Yes.
You remember the Second World War?
Just about.
How old were you in the Second World War?
Well, I was born in 1939, and then war broke out. No connection. But
it was you who caused the war.
It was my fault. Yeah. But I remember the American soldiers and passing. A lot of them came to Northern Ireland in preparation for D-Day and so on, and were marshalled and trained there. I remember them going past the top of our road in lorries. I remember the tank traps at the end of the road, because there was a railway line there. And I remember listening to the radio and hearing about the Red Army mopping up. And to me, this was a lot of guys in red uniforms with mops, as much as I knew as a 5-year-old.
And today, during this...
Austerity went on for quite a long time after that.
What went down?
Austerity, rations. They talk about austerity nowadays, but it's nothing like it was then.
And today, you're never supposed to talk about religion, sex, politics, or violence, but you brought up World War II, and we're having this interview today when Scotland's voting on a referendum, the United Kingdom...
The whole country's voting on
to pull out of the UK, and my first thought was, everybody's upset about Brussels and all that, but then you got to sit there and think, well, I'd rather them battle it out in Brussels, because Europe had 2 very costly world wars, and I almost wonder sometimes if Brussels is kind of letting the steam out every day, working through these problems instead of waiting till the steam builds up. So
it's certainly an argument. Problem is that it's brought so much bureaucracy with it. It's
right, sure.
Strangling everything. I've always hated rules and bureaucracy.
I've just never followed them.
I've always wanted the freedom to develop and progress and so on. And the continental Napoleonic tradition is to have rules for everything, all written down in a great long code. The British tradition, to me, is that you're free to do as you like, as long as you don't frighten the horses, as long as you don't
as long as you don't frighten the horses. I love that.
As long as you don't exceed the sensible limits. And there are laws which are codified in a fairly straightforward fashion, and you don't have to have a single law for every offence. there's a law.
So I take it you voted to succeed from
I
the...
haven't voted yet.
Are you willing to go on the record for your vote, or is that a private matter?
No, I'm weighing it up. I think I'm possibly would vote to leave. But it's a close run thing. There are lots of arguments about it. But I just feel that the European Union, which we joined, was a trade arrangement, which is good, great, free trade, I'm all for it, but more and more rules. Why should we have to ask 27 other countries whether we can do something or not and be told we can't? I think the negotiations to try and get concessions show that concessions are simply not available. And then, how can you possibly stick together 29 and maybe 35 countries, all so absolutely diverse in every way, and expect them all to do the same thing? It's nonsense. It's busted fresh.
I can't even do anything to get my 5 sisters to agree with me,
No.
let alone 29 other countries. Why we're on politics, I'm going to throw you under a bus.
Yes.
Because 81% of the people listening are Americans, and one of the presidential candidates is Trump, who owns a golf course or two in Scotland.
He's reopening it tomorrow.
So tell the Americans how about Trump's dealings in golf courses in Scotland. How's that been working
Well,
out?
he's certainly shaking them up a bit. I don't know what he's done down in Turnberry. It's a beautiful place and beautiful course.
And Scotland claims to be where golf was invented, right?
Yes, certainly it was first codified, and rules of golf were drawn up and so on. The Dutch claim it like they claim football, like they claim everything. But
The Dutch claim it?
Yeah, but...
Well, the Irish claim the mulligan.
Yes, well, the Irish would claim everything if you give them a couple of pints. Yes.
Can I tell you my favorite Irish joke?
No, please.
So you were born in Ireland. This is my favorite Irish joke. So in Rome, they were digging down underneath Rome, and they found copper wires. And the Italian said, "Look, we invented copper wires." And the Irish said, "Well, we dug down underneath our cities, and there were no wires because we invented wireless."
Yes, I like that one.
So we're on your journey. You got out of school. You're an oral surgeon at 1961. When did implants come on the scene? When did you go from complete exodontia?
That's one of my big sadnesses as leader and as dean of the dental school here, that we couldn't get our prosthodontists to cooperate and develop. We could have been in there very early because we had connections actually with Brannemark.
PI Brannemark.
Directly, personally, some of our trainees worked in Gothenburg. I went to Australia, what was that, 96 or something like that, and worked with a chap in Perth there, and I saw, the benefits and the usefulness of implants. But we just couldn't, and we ran up against a state system. We had a patient here in Glasgow who was prepared to put a very substantial sum of money into development of the system so that he could benefit from it. And there's a strict rule in the NHS that there's no mixed funding, and that things have to be kept separate, so it never happened.
But I'm
sad about that.
I want you to talk about it more, because a lot of these younger dentists that are like 30 years old, they don't realize that when I was in dental school from 84 to 87, the oral surgeons placing implants were tarnished as crazies, hooligans. The one in our dental school, they called him the barbarian.
Yes.
The guy, when I started my practice in Phoenix, there was one guy doing implants, and everybody called him the butcher.
Yes.
And sometimes these dentists would, in small cities that would start doing this, the first time one of their implants failed, the state board would take their dental license away. And now everybody's like, oh yeah, I want to learn how to place it. So remember that historical lesson, that just because only one guy in your study club believes in something and is trying something new, before you go throw them under a bus, realize that we're always going through this in dentistry.
That's the problem with the state system and the rules. It's back to what we're talking about. It's the same thing. You have to allow for people to experiment and innovate. I can remember actually removing subperiosteal implants, which I must say, having removed some, what was left was not a pretty sight. Some of them worked okay, but wasn't a successful
Gosh, those
technique.
are amazing to do and watch.
And then I can remember, I remember going to sit in on a course by Leonard Linkar in London. Must have been about 1970 or something like that. He was a big salesman, you know. But those implants, my main criticism of those was quite often the ones that seemed to work were ones that probably weren't needed in the first place. You know,
Is he still around, Linko?
Linko must be dead by now. Well, God, that's a terrible thing to say, but I mean, I'm talking...
Linko, if you're listening to this, email me, howard@dentaltown.com. When you start hearing people talk on a podcast that you're, by God, you have to be dead by now.
Well, my guess, he must be 100 years
yeah,
old.
I mean, I would assume he is.
Yes. But, and there's a guy, Ron Cullen, but these guys were too far ahead. They were chancers to some extent. But you have to give them credit for taking the idea forward. And it certainly worked for some people, but it wasn't a generally applicable thing at all. This chap Cullen, we opened a dialogue with him at the London Hospital, and he came and he spoke to my then Professor Gordon Sievert, and I can't remember what he said. Do all your patients a success or something, some sort of grandiose thing, and Gordon sort of said no, and I said, well, in that case there's no point in talking to you anymore. So he was a strange sort of character.
So let me ask you a professional question.
Yep.
You're an oral surgeon.
Yes.
Do you think only oral surgeons should place implants, or do you think the general dentist, the family practicing dentist, should be placing implants?
I don't care who does it, as long as they're doing it properly, and as long as they have a degree of training. Recognized training. I'm stuffy and old-fashioned, and I don't believe it's because somebody sets up a practice and says, I'll train people, that necessarily is satisfactory. If you're involved with the formal academic system, at least there are standards, and there are inspected and approved standards.
We get so Dental Town, we get courses submitted for our online CE courses, and I would say implants courses are the ones we reject the most. I mean, people will submit it, and it's exactly like you say. Somebody filmed and did a bunch of cases and all this stuff, but it's the world according to one person.
Yes. No, there has to be this dialogue. I mean, when I was early days in postgraduate, there weren't all these courses around, and then lots of them came up, and there were, of course, but a lot of them tended to be off the wall. They were on the edge of what was acceptable to the establishment specialists, but then the establishment specialists were guarding their own territory as well. So, I believe in academic dialogue and so on, but somebody's got to make their case.
Help some of these kids out. They go to these dental conventions, and there's literally 175 different implant systems you can buy. How would you help them pick a system when there's 175? I mean, you certainly can't go analyze 175 implant systems.
I would go the formal academic route and take advice from somebody whose advice you trust. And I still think that, it's an academic's job, it's a dental clinical academic's job, is to appraise things, to be skeptical, and to look for evidence and so on. There's a lot of talk about evidence-based medicine nowadays, but evidence-based medicine is very limited because most patients you see are a one-off, and there isn't an answer for everything. It's very good for therapies like drug therapies and so on, where you can make comparisons, and of course the outstanding ones are the oncologists who've always done that and do that very well. But you've got to appraise each individual patient and do the thing, but it's your responsibility, but it's your responsibility to make yourself as informed and never be as certain in your own mind as your patients expect you to be. You know, you always have to be aware of the fact that you don't know everything and it doesn't always work out. So you sort of feel
What percent of humans never get that? It seems what percent of humans do you think are not aware of what they don't know? They seem to always be fervently, religiously telling you what they know, and you always have to ask yourself, do you think this person's aware that there might be something that they're not aware of?
I mean, most clinical practice is uncertain. A lot of my clinics up the road here were full of patients whose problems were largely psychosomatic. A lot of the TM joint patients, facial pain patients, never mind the burning mouth patients and so on, which tended to get shuffled off to an oral medicine clinic for a lifetime. But you know, a lot of these patients, and you had to try and empathize and realize that it was just another TMJ to the guys in the clinic, but to that patient it was a lifetime experience that they were going to tell the whole family about, and everybody down the pub.
So
the
some
first thing I used to say to them was, look, you don't have arthritis. And you could see them relax, because, you know, to them arthritis meant they start in your jaw and you finish up in a wheelchair. You know, you have to realize that people are frightened of things.
So a lot of dentists talk about TMJ as extremely mechanical. The bite, the hinge, the joint. Some people think it's more neurological. Where do you weigh in on that?
I say it's psychological. It's an indication of worry, an indication of tension.
So you think it's more stress related than mechanical?
In all the years I used to send on, I would cheerfully have sent on patients for surgery or joint adjustment or replacement if I thought it was indicated. And in all the years I can only remember about 2 or 3 that ever went that route. Vast majority of people were quite comfortable and would settle down and would learn to live with the condition and eventually forget about it.
I saw a major study done that thinks that the entire lower back pain treated by chiropractors is completely stress related.
Well, I think an awful lot of medicine is. And you know, if we're talking about way back in the wartime and so on, you don't get problems like that then, because people have problems which are much more demanding.
Because people are what?
They have problems that are much more demanding. They don't have time to think about their comforts and so on in the same way. It's a disease of affluence, really.
Stress?
Yeah.
That's interesting. Stress is a disease of affluence. Yeah, I know, and I see
So
that.
we're getting all philosophical.
Well, it's okay to get philosophical because you know it's not every day you get to talk to somebody who's been doing dentistry since 1961. But I tell you, even at 53, the millennials always drive me crazy because they're always talking about in college, like, well, I don't know what job I should do to have the most meaning and purpose, and I'm trying to have the most meaning in my life. It's like, God dang, when I was a little kid, you just worked all day, every day trying to eat.
Yeah.
And pay your electric bill. And nobody at the Boeing factory or the copper factory or sitting on a combine 12 hours a day was sitting there searching their navel trying to find out what gave them the most meaning and purpose. They're just trying to pay the bills. So trying to find a job that's meaningful and purposeful is a sign of a society's affluence.
I mean, I've been very fortunate in my career because I've had enormous variety in activities. Gone through being a clinician, being an educator, and being an administrator, and being to some extent a politician, and being to some extent a judge and jury, and the General Dental Council, and so on, and in the appointments committee and human resources, as they call it now. It's a tremendous variety, which has been great fun. It's been great fun to do it all around the country and all around the world, and have friends and contacts all around the world, and so on.
So let's go into political. What political wars do you have to weigh in on? I mean, what are political conflicts in dentistry in Scotland like? What are they over?
Well, there was a problem which became greatly politicised and publicised in that everybody wants to have NHS dentistry because basically they don't want to pay for dentistry. They want the best, but they don't want to pay for it. And that's not possible. But what they can have is a reasonable level of service. But there should be honesty in the business. You can't have the very best, the most luxurious, absolutely highly desirable implants and things, very expensive, and not pay for it. Somebody's got to pay for it.
Mm-hmm. Oh no, you don't. It's free.
So I think you can have a basic service which leaves you pain and sepsis free, and for most people with reasonable degree of prevention, that's probably sufficient. Personally, I don't think you need your teeth whitened every month, but that's
well, it's a problem like in the United States. Like
peacockism is
if
fashion
someone
nowadays.
has cancer, and you say, well, this drug is $80,000, and it will only increase your life expectancy 10%. And every single American thinks their insurance should pay for that. But if you go back and raise their premium $10 a week, they'll all scream and yell. It's like, it's where do you draw the line?
I mean, there isn't a perfect system, so I believe in a mixed system.
Right.
But I would like to see some of the boundaries broken down a bit so that people could have provision up to a certain cost level or sophistication level, and over and above that, if they want it, they have to pay for it.
You know, it's
and to some extent the mixture now of private practice. I mean, when I came to Glasgow, and the years before that, there wasn't any private practice in Glasgow. There were about 3, I could nearly name them, 3 or 4 private practitioners, and everybody else worked in the NHS. Now it's very different. That's better in some ways.
Now what percent are mixed?
I couldn't say. I'm out of date. I would say, well, I don't know of any practice that isn't.
That isn't what?
Isn't mixed to some extent.
So they take private and NHS?
Do some patients under private contract. And there are now a number of, like this one, a number of exclusively private practices. Say, in the old days in Glasgow, there have been about 2 or 3 of those. One of those was my other hobby horse I do want to get on to, which is dental history. John Mingy's Campbell practiced just up there, just up the road a bit.
What was his name?
John Mingy's Campbell, Menzies Campbell, Mingy's Campbell. And he qualified before the war, and he went as a postgrad to America, or was it Canada? Terrible, I should remember. But he came back anyway. When he was there, he took up a study of dental history, and he became a very scholarly enthusiast for dental history, and devoted a lot of his life to it. He also was very keen in prevention at very early days. He was on when the first radio stations in Scotland in the 30s. John Mingy's Campbell used to give dental health advice on the radio and so on. So he was a long time at it. He was a character. I think he must have been a difficult character, because if you look at his career, he tended to be in one place. He mainly was in his private practice, but he would also work with the dental schools. But he didn't work with any one of them for very long. He would move from one to the other, and I suspect he fell out with some of them. But he became a very wealthy and successful practitioner. But they say he had an advertisement in the Exchange and Mark. Now, the Exchange and Mark was a paper for people who bought and sold anything. And he used to have an advertisement in every week which said, collector interested in items of dental interest. And he amassed a tremendous collection of stuff, including one which particularly interested me was quite a magnificent collection of dental art, which is in the Royal College of Surgeons in Edinburgh.
Which is about 40 miles away from here?
Yes, 40 minutes in the train.
So do you live there?
No, I live out the other way.
Will it be open Monday?
Yes.
Greg, you want to go see it Monday?
I would highly recommend you to go. The Royal College of Surgeons in Edinburgh is quite close to the railway station, Waverley railway station, and In there is the Surgeons Hall Museum, which has recently been refurbished, fantastic medical surgical museum, but it also has the John Mingus Campbell collection of dental memorabilia and of paintings, all sorts of instruments.
And what's the website for that? You know the website?
Well, it would be RCS Ed, Royal College of Surgeons Edinburgh, RCS Ed, which is RCS Ed AC UK, I think. Well worth a visit. It's quite a unique collection. I'm interested in art and I'm interested in dental history, so putting the two together leads you into quite fascinating byways. And I've been in touch with the National Dental Museum in Baltimore and BDA here, and the Mingus Campbell collection is about equal in size to either of those.
Now, where is considered the first dental school?
The first dental school is Baltimore.
It is Baltimore.
Yes, the first dental school in the UK was in London in about 1860 or so. But the Dentists Act of 1879 is when the dental schools really became codified. That's when they opened in Glasgow and Edinburgh virtually simultaneously, and in London. And the Royal Colleges of Surgeons were responsible for the qualifications. It was the LDS, the Licensed Dental Surgery. You don't really have the equivalent of the Royal Colleges in the US. It's a different system. But they gave the LDS, so this dental schools then, they mainly grew out of dental dispensaries in the big cities, which provided free treatment to the needy and poor and so on. And then did some training, but most people trained in practices as apprentices, but they would also take classes and so on at the dental schools, and then they took the LDS qualification. The first BDS didn't come until about 1909 at Birmingham.
And that's a Bachelor of Dental Science?
Yes.
And before that it was an LDS?
The LDS.
Which was a Mormon dentist? The Church of Mormon?
License of Dental Surgery.
Did you catch that joke?
No.
Oh, have you heard of the Mormon Church?
Of course, yes.
Well, they're called LDS.
Are they really?
Latter-day Saints.
Of course they are.
So, do they still use LDS anywhere in dentistry?
Yeah, people can still take the LDS. It's now developed into a qualification which can be taken by people who want to come from other countries to practice in this country.
And become an LDS?
Aha.
So in Arizona, the LDS dentists are in Utah, or in my city of
Yes.
Phoenix and Mesa and
Well,
Gilbert.
tell them they can come to England, come to Britain and get a proper LDS. No, it's interesting. I've got here which I'll give to you. We did a symposium on the history of dental education a few years ago. It's been rather slow to come to publication, but it's now published. And we traced the history of dental education in the UK back to the Edict of Nantes, which is 1203 or something, which is when the monks were, it was prescribed for monks to draw blood. So they developed, barber surgeons and so on all developed from then. So I think you might find some of the earlier parts of that interesting.
So when would you say that the first dentist graduated?
Oh, the first dentist to graduate would have been, well, strictly speaking, it wasn't graduation, it was licentiate, a license, not a degree, but so that's getting a bit pedantic, but it would have been 1879, and the first person...
That would have been in Baltimore? Or are you talking about
I'm talking about the UK.
The UK. It had been in 1879?
Before that, 1879, yeah.
And what would they have been doing in 1879? What procedures would they be doing back then?
They'd have been extracting a lot of teeth.
Would they still been doing any barber stuff?
No. It was. They'd have been extracting teeth and making dentures. and you go back far enough, so we were carving dentures out of whalebone and all sorts of difficult techniques like that, and using extracted teeth and there were replanting teeth way back in Rolison's time. That's about the beginning of the 19th century. But of course, it didn't work. But didn't stop them trying. They did stop teeth or fill teeth with gold, and even amalgam was invented way back then. So there were various techniques like that, and gutta percha and so on. There were ways of doing it. They also did certain amount of crude orthodontics, ways they used pegs and things, all sorts of weird techniques and so on. I'm not a big expert in the mechanics of things. I'm more interested in the organisation, the education. But we were certainly doing a lot of things like that. But the interesting thing was that the curriculum that was set out for dental education in probably about 1860 or so for the LDS England, the first one, was followed by and large until about 1950. It didn't change all that much. Obviously the content within it changed, but the general organisation of it, the subjects you started, well, latter days you did a little bit less metallurgy in your first year and a bit more anatomy and so on. But a lot of the work was done in the dental labs, of the practices and so on, and people spent a lot of time making things. Well, part of my training was spending a lot of time in setting up full dentures and so on, and then having the instructor say that's not very good, and putting it in the bin, making you start again. They were tough taskmasters in those days, but so that was the beginnings of dental practice and so on. But a lot of it was extractions.
Greg, you know what we have to name this podcast? We'll call it The History of LDS. And all my Mormon buddies will think, what? What's Howard doing on the history of LDS? And they'll have to listen to the whole show to figure out that it's the history of licensed dental surgery.
The license in dental surgery, LDS.
Let's name it that. Let's name it The History of LDS.
LDS, RCS.
With Dr. David McGowan. Oh my God, that'd be hilarious.
So, I was talking about Minnie's Campbell and the interest in the history of dentistry, which has been quite remarkable here. We have our own group, which we've named for one of the leading members, Henry Noble. We have the Henry Noble History of Dentistry Society, which has about as many members and is as active as the Lindsay Society, which is the national society for the study of dental history. And that's named after Lillian Lindsay, who was the first woman graduate in dentistry in the UK.
And what year was that?
I couldn't be sure. I need to look it up, but it's about, you're talking about 1899.
Did you hear Baltimore just had the first female valedictorian this year?
What is a valedictorian?
Oh, I'm sorry. That's right. That's what all the international people kept asking.
Yes.
That means you graduated with the highest marks in your class.
Right.
So she probably got almost a perfect score.
And that's the first time.
First time a woman has become the valedictorian, which was so romantic because it was the first dental school in the world and the first female valedictorian.
Well, I find that quite remarkable.
And she's planning on being on the show. I asked her to come on the show and talk about it.
Well, my experience in dental education was that the female students always did better than the males. They always worked harder and got better grades and so on in their exams. So there were outstanding examples otherwise, but by and large. And the other thing is you could usually read their handwriting, which was a distinction to most of the male students. But so we actually have a meeting of the Lindsay Society in October the 9th in London, which is a joint meeting with the American Academy for the History of Dentistry.
When is that?
It's the 8th and 9th of October in London, and booking is now open. And the Lindsay
What's the
Society,
website for that?
It would be the easiest way to get to it is through the BDA, British Dental Association, Lindsay Society, Lindsay.
So it's the Lindsay Society, Lindsay,
Lindsay, Lindsay Society.
Lindsay.
Yeah, 54th annual conference.
Lindsay
Society.
Lindsay.
And it's at the British Dental Association.
Yeah, let me see.
Where's
Where's it called? Where's it at? Lindsay Society. Okay, Lindsay. And how many people do you expect at that meeting?
50 to 100 probably.
Wow,
maybe more. The last meeting, well, that's actually a report of the last meeting of the Lindsay Society. We had about 50, 60 people here, and that was just the UK. But whether you get more or less in London depends. Some people like to go to London, some people prefer not to go to London.
So where would you rather go to, London or Paris?
It'll be in London, and Paris is the next year. We're having a meeting with the French Society for the History of Dentistry.
The Pierre Fauchard Academy?
No, it's not. I don't know. I'm not absolutely certain what the organisation is, but there is a French parallel organisation. I think the Pierre Fauchard Academy is maybe more formal. We're having a joint meeting in Portsmouth next year. So we have, active society involved with history of dentistry. This is the magazine of the Glasgow group. We produce a magazine twice a year, and so the Lindsay Society in October. I will become the president at that stage. I'll be inducted, as they say, as the president.
And you're going to be the president?
Mm-hmm.
How cool is that? And what? So let me ask you. Let me ask you some more modern day history. So,
Sure.
You've been doing this half a century, from 61 to 2016.
Mm-hmm.
What areas of dentistry do you think have gotten a lot better, and which areas do you think have gotten worse? I mean, they always say it's 2 steps forward, 1 step back. Like, I'll give you some examples. When oral surgeons started out, they pulled all 4 wisdom teeth just because they existed.
Just because they're there. Yeah.
Now you see a lot less wisdom teeth removed. What talk about that? Have you noticed that in your half century of watching this?
Yeah, I find this quite fascinating. Again, it's partly driven by the paymasters, and it suits the government paymasters to reduce the number of these operations they have to pay for, whatever way they're paid for. So the drive, there's an organisation called NICE, which I don't think is very nice sometimes, and that's the National Institute for Clinical Excellence. And it produces guidelines on various things across medicine. And then these become,
For the UK?
For the UK. And these become protocols within the health service, and they're very, very influential. And the NICE study came up with the conclusion that wholesale removal of wisdom teeth produced more complications, and it wasn't worth it, and so on.
So what's it called? National
Institute for Clinical Excellence. It's actually a rationing committee.
Okay.
But that's what it's called, and they do meta-analysis and things, and they come up with conclusions. I don't always agree with the conclusions. That would bring me to another hobby horse of mine, but we'll not go that way yet. But as far as wisdom teeth are concerned, now the number of people having wisdom teeth removed has now gone down a great deal. But of course,
how much of a great deal?
Couldn't say. I'd have to look it up. That's proper academic won't make up a figure, but I know where to find it through there. But very dramatically less. When I was in Aberdeen, we looked after that region, and we were a sort of wisdom tooth removing factory, and we would see the patients, and we used to have operating lists under general anaesthesia 3 times a week, and we would do probably about 12 patients in each session. We had a fantastic anaesthetic service, and we were pretty slick surgeons, and most of those would be wisdom teeth. So nowadays that wouldn't of course happen at all. But of course the price is beginning to come through, and people are now showing up with problems from long-standing pericorneal infections and from retained wisdom teeth and all the complications that you get.
So you think the pendulum was? Do you think the pendulum was we pulled all the wisdom teeth, too many? Do you think the pendulum has swung back to now we're pulling the right amount, or
I'm
do you
sure
think,
it has, and it'll settle in.
or do you think we're not pulling enough? 25, 30 years ago in the United States, everybody was saying that circumcisions were just religious. There was no evidence. So it was the all-natural thing to stop doing circumcisions. And then these parents would be taking their kids in for urinary tract infections over and over and over and over. And then they'd go back and get their boys circumcised at age 4, 5, 6, or 7. So the pendulum's always...
All are done and swings back again.
Yeah.
But the anatomy lecturer in the college in London used to say that the purpose of the wisdom teeth was to Rolls Royces for Harley Street surgeons, and so that's true. But I used to teach obviously about these things and remind people that people used to die of pericornitis.
Have you seen people die of pericornitis?
No, I never did. But if you go back to the days when days before antibiotics and before there was efficient treatment of infection, people used to die of pericornitis. And in fact, there's a famous novel by Thomas Mann called Buddenbrooks, and there's a description in that of someone nearly dying of pericornitis.
Well, let's talk about that. I've only got you for 5 more minutes. Mm-hmm. And we have Ashley Ladder waiting in the wings. They haven't invented a new class of antibiotics in 30 years. And you got a specialty in microbiology too. Specifically, I want you to address the fact that there are thousands of dentists around the world, and you're talking to a lot of them, that every time they do a root canal or pull a tooth, standard script for PenVK, amoxicillin, Keflex.
No, I do disapprove. We've done quite a lot of work on that, and we did a study. There's a thread currently on your organisation.
Dental Town.
Yeah, there's about do you treat an abscess by incision or do you give antibiotics first? Well, I'm tempted to put in the old adage: never let the sun set on pus. And get in there and incision.
Let's name this. Never let the sun set on pus.
Incision and drainage.
But is it incision and drainage?
And say you get in there, and if you're going to use an antibiotic, use an effective one and use a lot of it. But you only need to use it for a couple of days. But
so here's the confusion. I don't like to talk about what everyone agrees on. That like I look like Matt Damon. I mean, let's not talk about the obvious. Let's talk about the fact some oral surgeons say one of the ways I manage an infection is to drain, as I'll pull the tooth and give them antibiotics. Like I may give them oral antibiotics an hour before, but to manage, so instead of incise and drain, they'll pull the tooth with infection. Other people say no. Leave that tooth alone and manage the infection with antibiotics for, like you say, a couple of days.
Well, pericornitis is a special case because it's a difficult and quite invasive procedure to remove that tooth. I'm more thinking about other teeth with periapical infections and so on.
So on a mandibular tooth with pericornitis, you would want to do what?
I would probably manage the infection first.
With antibiotics?
Yes.
And what antibiotic would you use since you really don't have a culture and you're shotgunning in the dark?
Particularly favoured was amoxicillin, 3 gram preparation. So really sucking great.
3 gram over how long a time?
We used to use this was first formulated for venereal disease clinics when the patient couldn't be relied upon to take their medication. So instead of giving them tablets to take over a fortnight or 10 days, it gives them 3 gram sachet, which is a lot of antibiotic and may have undesirable effects in your gut temporarily, but it really gave a sucking great dose of and was very effective.
So you're saying when you
This
treat a
formulation
patient
for
pericornitis, their burning sensation will go away also?
yes, that's right. Good, some of those things.
Two for one.
No, it's. I believe that we've done the antibiotic dosage wrong over many years. We should give more for a shorter time. People don't take them for a long time anyway.
Yeah.
Once they feel better, they stop taking them.
But a lot of people think that builds resistance to antibiotics.
No, that doesn't. That's actually better for resistance than long-term exposure in a lower level. That's this good theory behind that.
Okay, what about an infection on an upper tooth? You would go right to the extraction with antibiotics?
Extraction or drainage of some kind, maybe opening up the tooth for drainage, or just simple incision if there's a swelling, a sizable swelling. So,
I want to ask you another controversial question. Americans are blaming this opioid addiction on physicians for prescribing narcotics like hydrocodone, oxycodone. America had 41,000 people die last year from opioid addiction. What do you? So someone comes in, you're pulling their wisdom teeth. They're going to be uncomfortable. Are you still a believer in opioids, or do you?
I never used them for that purpose.
You never used them for that purpose, and that's something.
I can't.
Greg, that's what I love about this show. When you come to the UK, where most people, after they place an implant or wisdom tooth, they give Motrin or aspirin or Tylenol. In America, it's a standard narcotic. So what?
Well, I mean, way back we used to use aspirin, and then we used paracetamol, and now
Paracetamol, which is what
Panadol or
which you call Tylenol, acetaminophen.
No, that's an interesting one. That's different. It's not the same thing.
Okay, what did you say?
Paracetamol.
Paracetamol is not acetaminophen.
No, it's not acetaminophen.
Okay.
Well, have we got time to tell you a story about acetaminophen?
Yeah, absolutely.
I was at a dental meeting in Dublin. And Dublin's a very convivial place, so we had a super dinner in Trinity College, Dublin. And I went and behaved my usual way. I think I had a pint before I left the hotel, and then I had the usual drinks beforehand and a glass of wine, and I collapsed halfway through the dinner. I went outside for a pee, and I actually felt faint and lay down and collapsed. And fortunately my neighbour was a physician, so he went out to see if I was all right and so on. But of course they couldn't do other than call an ambulance, so I went down to St James Infirmary, and it was in Dublin, in the ambulance in my tuxedo and so on, and I duly recovered perfectly well and was sent home, and they said stay another night in Dublin, but I couldn't, because Michael Jackson was appearing in Dublin that night, and you couldn't get a room in Dublin, so I actually left and drove down to Cork. But so I wondered why this had happened, because it never happened to me before. And then I realized when I was reading a Patricia Cornwell novel, and she said to her lab tech, don't take alcohol when you're taking acetaminophen. And I thought back, I'd actually taken Tylenol before I went out for a headache or something. And the reason I took Tylenol was because I had a free sample from a previous conference. And I put it together, and I reckon it was the interaction of acetaminophen and alcohol.
Well, you know, acetaminophen
led to me finishing up in hospital on this.
There's been many articles that acetaminophen, they put warnings, do not take with alcohol. Mm-hmm. And a lot of people say that Johnson & Johnson, when they read those 10K annual reports, that the settlements are about $1 billion a year. Mm-hmm. I have one of my staff members, her daughter's best friend, after a night of drinking, took 2 extra strength. And when they found her in the morning in a coma, and she died the next day. So acetaminophen and alcohol is incredibly toxic.
So I was lucky to get away with it. But no.
But I can't imagine anybody calling an ambulance.
There's good evidence now that paracetamol, Panadol, paracetamol and ibuprofen taken together are an effective post-operative medication.
I can't imagine anyone calling an ambulance if they saw an Irishman pass out drunk on the sidewalk.
wasn't on the sidewalk.
Wouldn't that just be normal
Trinity
behavior?
College, Dublin. However, no, the one thing I would like to refer to before I finish, most of my life was spent, my main research interest was in preventing dentally related endocarditis. And I had a lot of fun with a lot of people. I did experimental work and so on. And I worked particularly with David Durack from latterly Duke University and so on. I went through my life. I remember the day we conquered America. We had recommendations for prophylaxis in the UK, which were generally agreed. And we went by invitation to the American Heart Association, had a conference with all the guys in Washington. And
what year was this?
Oh, I wish you hadn't asked me that. It's quite a long time ago. I can tell you how you can look it up. It was the day Nick Faldo won the Masters. Because I was in the bar watching this with a crowd of other people, and the bar emptied, and the only
look it up, Greg. Nick Faldo won the Masters
for the first time. I was left the only person enjoying this because all the Americans left the bar in disgust. But however, we did. Our recommendations were then adopted by the American group, almost exactly the same. And have remained through to this day. But what's happened in Britain, this NICE group looked at the situation and they said prophylaxis was unnecessary. So now, legally and in every other way, organisationally in this country, people don't give prophylaxis. And this is where history comes in. Because what's happening is cases of dentally related endocarditis are beginning to occur again, and they have actually risen. Now, it's arguable whether giving everybody prophylaxis is justified when only a few people are affected. But I would go with the Europeans and Americans and say if anybody has a strong history, special history of previous endocarditis or significant heart valve problems, I would certainly give them prophylaxis.
And what about for artificial joints? If the joints are moving?
Never. Not required.
No antibiotics.
I wrote an article about that 30 years ago. I studied all the evidence. It's not required. I can almost say it's never happened, but it's so unlikely that it's certainly not required.
Well, thank you for a very long and distinguished career in dentistry.
Well, it's been very interesting. Thank you for giving me the opportunity.
Oh, it's amazing. And I'll tell you what, I'll give you a marketing tip. Our generation would sit in a chair and read a book. Mm-hmm. And all of our parents would complain that nobody read enough books because they're boring.
No, nobody reads books.
Well, if you read this book into a microphone and you put this as an audiobook on iTunes or Dentaltown, the 30 and under, they pretty much just do audiobooks. And they do it while they're multitasking. They do it when they're driving in the subway, riding their bike, cleaning their house, mowing their yards.
It's much too boring for that.
Well, you know what?
That is a record. That was the whole purpose of the symposium, was to put on record the knowledge and experience of a group of dental educators over the last 50 years before they became unavailable, shall we say. And that was the whole purpose of it.
Well, I'll tell you something very interesting about Amazon. They call it the long tail. So before the internet, everything was sold in scarcity. Like a record store could only cover 10,000 records. A bookstore, a big one, could only cover 100,000 books. But when you come out with Amazon books, the long tail of 5 million.
Yes.
When you go to iTunes, the long tail of 5 million. And Amazon Books and iTunes will tell you they've never put up a song or a book that doesn't sell at least one unit every quarter. So it could be Tibetan music chants in on the plateau at Tibet, and somebody would buy the darn song every quarter.
I have to move the Department of Medical Education of Medical History at the University of Glasgow in that direction.
Okay. Well, hey, thank you for coming by and being on our show.
Well, It's always enjoyable talking about
Now we
yourself.
should go have a pint of beer together since we're
That's
both
right.
Irish.
Absolutely.
Should we do it in Scotland or should we jump back over to Ireland to have our
Well,
pint?
I think we could provide one here.
Okay.